If you have circulation issues in your legs, known as peripheral artery disease, and you live in the United Kingdom, I hear you. And folks in the NHS, they hear you. You want more attention given to research on PAD. Well, guess what? It is happening. We have Bert Bond, who is here, who's going to talk about a brand new research project in Exeter. Is that correct, Bert?
Absolutely, you've got that right, yeah.
How in the world? It is a disease that's more prevalent and deadlier than most cancers combined, and yet here in America, more than 70% of Americans don't even know about it. We just found out that 8 in 9 or 8 in 10 primary care doctors don't even diagnose it with textbook symptoms. Initially, they diagnose it as something else. So 5 in 6 PAD patients are not even diagnosed with PAD in a timely manner. Not sure the stats over there in the UK, but it's interesting when we have researchers such as yourself. How in the world did you end up with what we consider a foot fetish? Your interest in
So,
PAD?
yeah, sure. So, thank you. In all honesty, I've come to this quite late to the party. I was a vascular researcher and performing lots of different sort of research in the field, trying to understand how we can improve blood vessel function. And I wanted to basically apply this knowledge to a group that would have some, meaningful clinical benefit. And yeah, peripheral artery disease is quite underfunded here in the UK. There are far sexier things to fund, it would seem, when it comes to vascular research. So they're kind of a bit of a maligned group. And I feel like some of the work we've been doing over the last 3 years specifically really speaks to having some potential benefit for people with peripheral artery disease. So, that's why I'm quite happy to be here today and talk about some of those opportunities and some of the context for our work.
I think it probably helps to have Dr. Thanos Saratsis ahead of the Royal College of Vascular Surgeons and the head of research funding right now, because that just plays right into what you're doing.
Yeah, absolutely. And you can't do research without funding. It's just so difficult. So I'd like to think that things are going to be moving in the right direction for what is clearly a growing health crisis and also just on a personal level, people are just so disproportionately affected by this disease. So, anything we can do in this space is always a positive.
Well, tell us about your project. You have a presentation and I'll leave it to you.
Yeah, thank you very much. I'll share my screen then. And Joshua, if you wouldn't mind just confirming that this is coming through. So for the benefit on the call, here we go. I'll just put it in presenter mode. And for the people watching, that should be coming through now. Okay, is that okay, Joshua? Okay, I see thumbs up. Thank you very much. Cheers, Kim. Okay, so thank you everyone for joining the call or watching this online. I wanted to start with a special thanks really to Kim for inviting me to do this talk, and also Kim on behalf of everyone that's had anything to do or benefit from the Global Peripheral Artery Disease Association that you're so instrumental with. I just wanted to say thank you. I've looked at some of those resources. The work you're doing is absolutely brilliant. So thank you for that on behalf of a growing population of people. So thank you. So my name's Dr. Bert Bond. I direct the Vascular Research Group at the University of Exeter in the UK. And we are part of the Exeter Medical School, specifically in the Department of Public Health and Sports Sciences. I just want to make it really clear from the start that I am a researcher. I'm not a clinical doctor so I'm not an MD. I'm a researcher, so I have a P.A.D. So I'm not able to provide medical advice, but as I was speaking to Kim at the beginning of the call, I'm a researcher that's looking to apply some of our research into this space and to try and support people who have peripheral artery disease. So I mentioned, just for those of you who are across the pond, Exeter is in the southwest of England. We're in the county of Devon, which is quite often a tourist, destination for lots of people in the UK and abroad. I'm very grateful to my employers for having me at Exeter, because we're 20 minutes away from the beach. So thank you to my employers if you are listening. So that's where Exeter is. That's where I am. And I mentioned that I oversee the Vascular Research Group. What we try and do in my group is try and understand how certain lifestyle exposures might increase risk of disease, specifically vascular disease. And we do this by, on the left of the diagram, you can see there, we've developed multiple techniques to assess blood vessel functions kind of different ways. We can look at arterial health, we can look at capillary health, we can look at brain blood vessel health, we can look at arterial stiffness, we can measure these things lots of different ways. And then we try and understand the lifestyle exposures that might be good or bad, which you can see kind of in the pink there highlighted. So a good example of this is, we know that if you habitually have trouble sleeping, you are at an increased risk of vascular dementia. But we don't really know why. So my group at the moment, we're doing some studies where we're actually sleep restricting people to see if that changes cerebrovascular function in some way. And perhaps that contributes to this pathway of habitual sleep loss or sleep problems and vascular dementia. That's just one example. You can see all the different exposures that we have there. It might be exercise related or nutrition related. But what I'm going to be talking today is about ischemic preconditioning. But just the final, before I move on, you can take a look. There's a couple of 3-minute videos from my PhD students about what we're currently working on. They're on our webpage. We update this webpage every quarter or so, you can sort of stay informed of some of the things that we're doing. So do take a look at that. And of course, my email is on the bottom of the slide there if you'd like further information about any of that work. Okay, so why does this research matter? Why today? Why peripheral artery disease? Well, as Kim mentioned at the top, it's a growing health concern, and in the UK specifically, and it sounds like it's also the way in the States, where it's quite an underfunded disease for research. And what I wanted to do with my research group is try and pivot and get out of our lab with some of the research that we're doing and try and hopefully make meaningful benefit to those who have this disease as well as others. We understand that peripheral artery disease can be debilitating. And in the UK, if you receive a diagnosis of peripheral artery disease today, your clinician will tell you to do some structured and supervised exercise. That's the guidelines. But that's not necessarily helpful, because maybe you don't have access to a gym. Maybe you live in a rural community. Maybe you can't afford a gym membership. Maybe you don't have access to a personal trainer, for example. But also in people with peripheral artery disease, I'm sure people on the call will know, exercise can be disproportionately painful. So having spoken to people in our focus groups work who have peripheral artery disease, they've been very clear, and they've said to us, we would like other approaches to be explored. Now, I'm absolutely advocating exercise when it's safe to do so. Exercise is pluripotent in terms of its benefits, but it's not necessarily achievable for everybody. And so maybe there's something we could do in addition to or instead of. And one of those things might be ischemic preconditioning. I might call ischemic preconditioning IPC during the remainder of this talk, so I do apologize, but this is what I'm talking about. Ischemic preconditioning is when you use a cuff, typically on the arm, to restrict blood flow temporarily and then allow reperfusion, and then you repeat that cycle. So you might have the blood pressure cuff on your arm, and you might inflate that for typically 5 minutes, during which time you can expect to get pins and needles in your hand. The cuff will then deflate and the blood flow returns. And you might do that 3 to 5 times. Now, I just want to state from the beginning, this isn't something that we've invented here at Exeter. This is, a well-established vascular intervention that's been used across a variety of different models and purposes. So really, in the mid-80s, people were doing sort of surgical procedures, and we looked at how temporarily restricting blood flow to a part of the heart can protect that heart tissue when you've had a heart attack or you're undergoing cardiovascular surgery, for example. And so there was some animal data coming out, a lot of work with sort of dogs and pigs, and then later rodent models in the 80s. And then some human data started to come out in the kind of mid 90s. So it's kind of a well-established thing. And then at the turn of the century, about 2002, some data came out to show that this technique doesn't need to be restricted just to surgery. So if you use this blood pressure cuff on a limb, you can get vascular benefits from it. So it's really not something that we've invented. You know, there's a wealth of evidence out there, but it's something that we're quite interested in performing. So I just thought I'd share some data from my group about 18 months ago now. We measured people's blood vessel health using the ultrasound technique that you can see on the screen there. This is a technique called flow-mediated dilation. It's a well-established marker of endothelial function, so how healthy your blood vessels are. We basically look at how well that blood vessel can dilate or get wider. And the wider it goes to a stimulus, the healthier it is. And we measured this, and then we did an ischemic preconditioning protocol. So you can see that on the top left of your screen. We inflated a cuff around the bicep for 5 minutes, and then we deflated for 5 minutes. And we repeated that 4 times. And what we showed is that 20 minutes after we'd done this 4 lots of 5 minutes, the health of the blood vessel in the arm significantly improved by 1.1%. Now, that doesn't sound that exciting, 1.1%, but the outcome that we're measuring here, the ability to dilate, the units of that are actually in percentages. So it's a bit confusing. We've seen an absolute increase in this measure by 1%. So my flow-mediated dilation might be, let's say, 10%. But after the cuff protocol, I can have my blood vessel function dilate to 11%. That's an absolute increase of 1%. So it's not a relative change, but an absolute change. Another way to think about this is if you were to improve this number by 1%, that is thought to be the equivalent of a 13% reduction in your risk of cardiovascular disease. So a magnitude of 1% in this outcome is clinically meaningful. It's something that we care about. So we were quite excited by this. But what's really interesting is we decided to look at the other arm. Now, the other arm never got trained. So in this photo, we're training the left arm, 4 lots of 5 minutes on the left arm, and the left arm improved by 1.1%. But the right arm also improved by 1.1%. So in other words, we get the benefit on our left arm, which got trained, but we have a remote effect on our right arm, which also trained. And that's quite exciting. And in truth, other people have shown this as well from other labs. But where the novelty of our study lie was, okay, we then asked people to go on and do this at home 3 times a week for 2 weeks. And they only ever trained one arm. And again, we showed that both arms improved by like 1.2%. So that's quite exciting. What you do to the left appears on the right. And if we were to train your right, it would appear on the left. In fact, we actually counterbalanced that. We made sure that we looked at different arms both times. And that follows a previous study by a different group of about 15 years ago now. They did 3 lots of 5 minutes of cuff occlusion on the leg. Now, the leg is more painful. And I just want to make it very clear, talking to a group that may have peripheral artery disease, I do not advocate using a blood pressure cuff around the leg. When a blood pressure cuff comes on around the leg, you're deliberately restricting blood flow to your leg in a population where people may have difficulties in reperfusing that leg. So I'm not suggesting you do this at all. But as a proof of concept, these researchers, they recruited young, healthy people. I think they were about 28. And then some healthy and hypertensive elderly people. I think the average age was about 70. I'll have to double check that, but about 70. And they did this technique on the arm to take a look at how healthy is this blood vessel on the arm, having done the thigh cuff occlusion. And they showed again that there was a significant improvement in arm blood vessel function, even though they put the cuffs on the leg. So those are 2 different studies here that show that you get some remote effect from doing this 4 lots of 5 minutes or 3 lots of 5 minutes. Now, no one has actually performed it on the arms to see if you can improve leg blood vessel function. I'm happy to say that we are halfway through doing that study in my lab at the moment. And as of Monday, we'll be 50% of the way through, which is quite exciting. So we'll be the first people to take a look at that. But suffice to say that this technique, ischemic preconditioning, has benefits for blood vessel function. Now, my PhD student, Kais, is currently exploring this and is performing a systematic review, amongst other things. And what a systematic review does is it allows us to review all the papers that have ever been published in peer-reviewed journals. And we have strict inclusion criteria. So we only include the best, most well-designed, controlled studies in our systematic review. And we haven't finished this systematic review yet. So this, this data that you can see on the screen are kind of hot off the press. We just kind of pulled it for this talk, but we can keep the group informed with our findings once we've finished our systematic review. But what we have here is we've returned papers from 3 different studies that have looked at ischemic preconditioning and blood vessel function. There are lots of papers that have looked at ischemic preconditioning and some other health outcomes, but I'm just focusing on blood vessel function today. And we can see that one paper has looked at people who have diabetes, another paper is looking at people who post-stroke, and the third paper here is looking at those who've got coronary heart disease. And on our x-axis is the absolute improvement in blood vessel function. And remember, a 1% change is the equivalent of a 13% reduction in cardiovascular disease. So a 1% change is clinically meaningful. And at the bottom there, the big diamond, you can see the overall effect. And we can see the overall effect is about a 3% change. So there is reasons to care. And there's good evidence now that suggests that ischemic preconditioning can promote blood vessel function in people who have blood vessel disease. There are no data that are available that we are aware of in people with peripheral artery disease. And that is something that my group are trying to establish. And I'm going to be talking about that study a little bit later at the end of the talk. Okay, so hopefully I've kind of shown you some sort of convincing data that ischemic preconditioning can improve blood vessel function, but ischemic preconditioning has another benefit to the body. I mentioned right at the top of the talk that I actually work in public health and sports sciences. That's the department that I'm in. And my background before as a physiologist was initially in exercise physiology. And a totally separate body of evidence, not in clinical groups whatsoever, has shown again and again that ischemic preconditioning can actually improve exercise performance, including in athletes. Now, I just because usually at this point in the talk, people think about using cuffs in the gym, and you may be familiar with something called blood flow restriction training. This is not that. Blood flow restriction training is where you use a cuff at low pressure and you do exercise whilst the cuff is on. That's not what this is. This is just, again, sitting down at home for lots of 5 minutes of the cuff. You're not doing anything during that time. You could be watching TV. Okay, but we know if you do this, you can improve exercise performance. And I have another PhD student, Luke, who's exploring this as part of his research at the moment. But this is quite interesting because we know that people who have peripheral artery disease find exercise disproportionately painful. So this might be another vehicle by which people with peripheral artery disease could get some benefit of ischemic preconditioning. It's like a 2-hit approach here. So there are some, I think 3 or so papers that have looked at ischemic preconditioning and exercisability in people who have peripheral artery disease. And the data that are available are quite mixed. Some papers have shown there isn't a change. Some shows that there is a change. This is a paper where they asked people who had peripheral artery disease to do 5 lots of 5 minutes of arm occlusion every single day for 4 weeks. And they had a control group and they had a group that did the ischemic preconditioning. The control group did the arm cuffs, but the arm cuffs inflated to a pressure that would never occlude the blood vessel. So it was like a sham trial, just a very light blood pressure cuff that didn't actually do anything. So that was the control trial. So it's nice that they had a control trial in this study. But then they had a group that actually performed the ischemic preconditioning. And before I release the data on the screen, I just want to talk through what you should be able to see. Their measure of exercise performance was to invite people onto the treadmill to walk at 2 kilometers an hour. And they initially walked at a 0% gradient, And then every 2 minutes, the gradient increased by 2%. So it just got steeper and steeper and steeper. And then the patients reported, when they felt pain, so that's their claudication distance and their total walking distance before they decided to stop. And then also the researchers timed how quickly people recovered from that walking exercise. And we can see in the control trial here, there was no improvement in any of those things. Okay, that's not a surprise. It was a control trial. But in the participants that performed the ischemic preconditioning, we can see that there were significant improvements in all three of those things. There are other data in people who have peripheral artery disease showing that walking didn't improve, but their ability to do knee extensor exercise in the gym using it against some sort of weights did improve. So, it's a bit of a mixed bag. It's kind of early days to say with any certainty that IPC definitely improves things for exercise ability in peripheral artery disease. In research, nothing is a scientific truth until someone else duplicates your findings, right? Repetition and replication is a really important part of the scientific process. So it's early days. One of the things that clouds our understanding is the fact that people use different cuff protocols. And it might be 4 lots of 5 lots of 5, 3 lots of 5, or it might be every single day. It might be every other day. It might be for 4 weeks. It could be for 1 week. There's a lot of noise in those kind of studies. But that's kind of where we're at as a research field. And then finally, I just want to mention, and I'd left this till last, some of you might be slightly alarmed when I'm talking about restricting blood flow to, let's say, your arm. Is that safe? What does that feel like? So I wanted to provide some data here from a group of 80 to 90-year-olds. The average age was 83, and you can see in the top right-hand corner of the screen here the average age of people involved in this trial. And these guys, so there are 18 male, 12 female in the group that did the IPC, and they started performing ischemic preconditioning about 4 days after having a stroke. Okay, so we have our clinical group, and they are massively at risk of another stroke or another cardiovascular event because they've already had a stroke, they're 83 years old, and most of them had hypertension and hyperlipidemia, so high blood triglycerides, and also about half of them had diabetes. So this is a real at-risk population. And they were asked to do 5 lots of 5 minutes of bilateral arm occlusion. So both arms, cuff inflating 5 times for 5 minutes. And they did that twice per day. So that's a total of 10 sessions per day. And they did that for 180 consecutive days. So for 6 months, right, half a year. And this study reported no adverse events in this group. 5 individuals from this group reported mild discomfort, but they still carried on doing it. That's what the paper reported. And just a small caveat, the group that did this type of training, they experienced far fewer strokes over that 6-month period. So only 13% of the group who were doing the training had a recurrence of a stroke or a cardiovascular event, compared to 35% of the control trial that were matched for age and sex and cardiovascular disease risk. So even in these guys who are higher at risk, there was no adverse effects reported. What does it feel like? I thought I'd share some data from my own lab here. So this is data from 4 lots of 5 minutes of using the cuff on the arm, which is far more pleasant than doing it on a leg. And remember, I don't advocate doing it on a leg. Certainly, if you have peripheral artery disease, that's something I wouldn't recommend. But here on our y-axis, we've got pain measured in arbitrary units. So 0 is like no pain, 10 is maximum pain. And the dots are the individual data points. I like to show individual data and not hide behind means and error bars. But the gray boxes there are the average of all those data points. So you've got 4 boxes there. We ask people's pain in the last 30 seconds of each time they're experiencing the cuff. So in this trial, we've got 4 lots of 5 minutes. So we asked them 4 times. And on average, people are saying it's about 2 out of 10 for pain. in terms of how painful it is. But again, I just want to highlight, and I don't know if you can see my cursor on the screen, but if you can't, there was one individual that basically gave it 6 out of 10 for pain and they ended up giving it a 7 out of 10. But that's quite unusual. I just want to be transparent. I'm not selling ischemic preconditioning. I've got nothing to sell here. I just want to, try and make some inroads, and we're all on the same team here about improving vascular function in a target population. So that's what we've noticed. And some of the qualitative comments of people that have done this work have said, things like, it's not painful. They might describe it as a bit uncomfortable or some discomfort. They typically say that the first time you do it is weird and the worst, but then you kind of get used to doing it. A few people have said, and there are quotes that I haven't included on the slide, but a few people have said to us that actually if they were kind of watching TV, they would kind of not obsess about the sensation. They'd quite happily sort of zone out and it wouldn't be a thing. We've done some focus group works with people who have peripheral artery disease, and one person made it very clear to me that they would be very willing to do whatever it takes to try and improve their blood vessel health. So we've got a massively incentivized population that are kind of willing to do these things. But that's kind of where we're at with our own data. So just to kind of a quick recap before I talk about what we're going to go on do in the future, because we've got about 10 minutes left in this presentation maximum, and then we can maybe have a bit of an open discussion. I'm conscious of time. You can just come back right to the top of the start of the talk. People with peripheral artery disease have told us they want new approaches to be explored, new techniques, new interventions for their benefit. So we know that, and we're kind of responding to that. Ischemic preconditioning has been shown by other people as well as ourselves to improve blood vessel health, both in people who are already healthy and people who have cardiovascular disease. Ischemic preconditioning has been shown to improve exercise ability in athletes, as well as regular healthy people, young healthy people, and there is some emerging evidence to say that ischemic preconditioning can improve exercise tolerance, for example, walking in people who have peripheral artery disease. And then finally, it's generally well tolerated. So it's something that seems to be feasible and achievable. In short, I feel like there's enough here to warrant exploring as an intervention for peripheral artery disease. And we're not the only group that's doing this. There are other groups, kind of around the world that are exploring this space. And so, it's a very exciting time. So that's kind of like 20 minutes. A bit of background about us, what we do here at Exeter, and ischemic preconditioning. And you can follow some of that work on our webpage. And as we publish, we're big fans of science communication and outreach. So we have a rule: every time we publish a paper, we will now record a 3-minute YouTube video to put on our webpage so people can find that data and find it accessible. And so that's, our webpage is new, but as we publish in that space, we'll be growing that video library. But I just wanted to finish by talking about a study that we are running at Exeter. If you happen to be watching this in the local sort of Devon community, it's a very small study because we just want to start, and we understand that research is small increments in knowledge, and we don't want to rush ahead with things. But I'm very grateful to the funder for this as well, which I want to acknowledge: the public engagement with research. We've got research fund for this, and also the Exeter Paris-Saclay University Accelerator Award. So we have 2 funders, and we've worked with 2 consultants. 2 vascular consultants, and one of our members of our supervisory team for this work is a specialist in peripheral artery disease. So we've kind of put a really good team together, and we've got some funding to try and explore the feasibility and the acceptability of ischemic preconditioning in people who have peripheral artery disease. And this is a part of Kajs's PhD, Kajs, who I mentioned earlier. So this study, it's a very small study. We're just looking for 10 volunteers, people who have peripheral artery disease in the local sort of Exeter, Devon region. And we'd invite them to 2 visits to our laboratory at Exeter. And we will reimburse people for their time, £75 a visit. Each visit is a morning, so it's 2 morning visits. It's £75 for both visits, and we can reimburse all travel costs as well. So that's important. We're very grateful for your input. We want to work with you, and so we can sort of co-create our future research. If you wanted to take part, those 2 visits to our laboratory, I'll show you what they look like. But you'll experience 2 different ischemic preconditioning protocols. We will provide you with a measure of your blood vessel health. So we'll do this ultrasound measure on you. We can tell you what your blood vessels are looking like, and that's something you might be interested in. But then really it's opening up dialogue with you as an individual so we can learn about your needs, what you would like us to do in the future. Again, so we're all on the same side and we can try and steer our research in ways that you think would be valuable.
And so you're
So
in Southwest
Southwest,
England.
yeah, Southwest,
Okay.
yeah, Southwest. Thank you. So I can make that clear as well with any sort of handouts that if you would like me to provide. So if you were interested in taking part and you happen to be local to Exeter, this is what a visit would look like. First and foremost, we'd invite you in, we'd familiarize you to everything that we were going to do, and then and only then we would ask if you'd be willing to provide your informed consent. And there is no obligation to do so. You would still get paid if you didn't want to consent. That's absolutely fine, because we're valuable for you. We really value your time. We just want to make sure that people know what they're consenting to. So consent is really informed. So we kind of familiarize you and to all these different techniques. And then what we would do is we would perform a couple of different ultrasound techniques, which are minimally invasive. We do this with children. We do this. I've done this from 8 to the age of 94, I think is the oldest person I've scanned. So we do these sort of established ultrasound techniques to see how healthy your blood vessels are right now. Then what we would do is we would do our ischemic preconditioning protocol. Now, when we've talked to people who have peripheral artery disease, one of the concerns that they've said is that they're worried that when the cuff deflates, their artery might still stay closed because they have, arterial disease, and that could lead to critical limb ischemia, which we all know is bad news. So this work again we've got ethical approval for it. We've worked with vascular consultants that there's no reason to think that that's high risk and that's going to happen. So what we're going to do is using ultrasound so you can hear blood flow. We're going to allow you to hear the return of blood flow every time that cuff deflates, which should be reassuring. So we're going to be doing that. After we've done those 4 lots of 5 minutes, which is a standard protocol, not something we invented, we will measure and we will let you know, did it work for you? Did it improve that blood vessel function? Once we've done that, we will then invite you to our exercise lab, which is in the lab next door to our ultrasound lab. And we will show you the treadmill. We'll get you to wear a face mask where we look at how much oxygen you're using. We won't do any exercise with you, but we just want you to try out the equipment and let us know if this is something that you would be willing to do in a larger trial. I mentioned I work in a sports science department, so we're well as set up here to really measure the physiological response to exercise. So above and beyond things like how far could you walk without pain, which is important, we can also provide some physiological insight by using a face mask or using some near infrared spectroscopy, a laser technique, if you like, on the muscle to look at how well your body is handling oxygen. So we'll just introduce you to those outcomes and say, would you be willing to do this in the future? And also, could you help us co-create our exercise element? We've got some ideas, but that feedback will be very helpful. On the second day that you come in, and we'd actually probably counterbalance this, it's exactly the same, but we will try a different protocol. Rather than doing 4 lots of 5 minutes, we'd like to explore whether or not doing, instead of 4 lots of 5, maybe 8 lots of 2.5 might be more palatable, something that's a bit more achievable for people in a real world context. Maybe does it have the same benefit? Because 4 times 5 is 20 minutes. 8 times 2.5 is also 20 minutes. So they're matched for time, but they're delivered differently. And I know that if I was going to speak to a family member saying, I would like to restrict blood flow to your arm for 5 minutes, 1, it would sound a bit strange, but 2, it sounds a bit intimidating. But maybe 2.5 minutes is a sweet spot. We don't know. We'd like to explore. So it's very similar. And at the end of that, we will have a full debrief where we sit down with the individual and we say, let us know how you felt about those sort of things. Would you also like to join a steering group committee for a future trial? Having that patient input is so important for research, and having that patient voice is so important. So that's the study that we're running at Exeter. If you have any interest in that, please contact Kais directly, and you can see his email there on the screen. So Kais is running that trial. If you've got broader concerns or like to talk about it, then you can drop myself an email, and my email's been throughout this whole project, this whole presentation, sorry. So that's 31 minutes, which is pretty good for an academic. Usually they like to waffle. I try to keep it at 30 minutes. Hopefully that's kind of a bit more accessible and we've all learned something. But I'm happy to stay on the call for a little bit longer and talk a bit more broadly. But remember, I'm not a clinical doctor. I'm a researcher, but I'm excited to work in this space. So
Well,
Kim,
we're
I'll stop sharing my
excited.
screen if that's okay, and then hopefully I should be back. Yeah, that's great.
We are definitely excited that you're excited about P.A.D. We love every single angle, and it's all hands on deck with P.A.D. And you are 100% correct that patients are looking for new options, and especially minimally invasive options. And I think it's encouraging that this is something that you're applying that's already worked in athletes.
Yeah, and that's that. In all honesty, this is how I learned about it. To come back to your question right at the start, I do work in a sports science department. Technically, the sports science is part of our medical school here, so I'm surrounded by very athletic people, and this is how I learned about it. And I just thought, well, I also work with researchers that do a lot of work with people who've got cystic fibrosis or COPD, so which we think of as a lung issue. And if you're an exercise physiologist, what you care most about is the ability to extract oxygen from the air and burn it as a fuel in the muscle. That's what fitness means. And we know that the fitter you are, the healthier you are. And that's particularly true for at-risk groups. So I work in a nice space where exercise physiologists are making meaningful benefits for people who have perhaps lung issues or multi-organ issues, for example, like cystic fibrosis and COPD. The fact that we can improve exercise performance in athletes is very exciting because the magnitude of improvement there is very small. So yeah, that's certainly where I've come from, actually. I think, and then the fact that there's well-established literature showing that it improves vascular function. It looks like a double hit.
It's something, I mean, I know this is a really small study, and this could be just the beginning. I'm curious, we have Mike here in our in-studio audience who has been a co-host of our UK Hangout on so many weeks. And so I'm curious, his perspective, just from a patient's perspective on this type of study and the promise of it. But I would imagine just sitting here in the States, I'm like, why don't you come here and do something with some of our patients here already? It just seems so promising. But any plan across the UK at some point, if this works out the way you think, to say, hey, Dr. Saratzis, we need more sites. We need to do this across the United Kingdom.
Yeah, absolutely. So I don't want to temper any enthusiasm here because I don't want to sound like I'm selling snake oil.
Don't rain on my parade here.
No. I also don't want to sound like I'm selling anything.
I know, yeah.
As just an objective scientist, there is reason enough to think that this is worthwhile in exploring. I think that's where I'm currently at. But having said that, the potential is quite profound because we are working with a Canadian group that are developing cuffs that you can use at home, right?
Hey, Mike's getting excited about that.
Okay.
He says he's in Canada right
now. Yeah, I live in Canada now. I'm from Manchester originally, but I'm actually in Canada now. I've just got on my flight back from Manchester. I'm currently in Toronto at the moment on a layover, waiting to go home.
Okay.
So if I was still in the UK, I'd quite happily go on into this research project. Definitely.
Well, I mean, listen, I think what we're trying to achieve here, as much as we have a small study running, is like I said, scientific outreach. I think it's important that people know this exists, that we exist, and then perhaps we can, update the group, maybe in a year's time if we've got some good data or whatever. But the application of this, Kim, is very exciting because I know that if we have cuffs that you can program, you could do this whilst watching one episode of something in Netflix. That's 40 minutes, right? So again, that's very exciting. And the important thing as well is it's, even if it doesn't work, it's really unlikely to be harmful. So I think it's worth exploring, definitely. But yeah, the direction of travel and the body of research says, yeah, there's every reason to think that this will improve blood vessel function. Yeah, and here's the other thing as well, is if it does improve people's ability to do exercise, it might then make exercise more palatable for people with peripheral artery disease and more achievable. And we know how beneficial exercise can be for that group. So, you know, that's also exciting.
And Valerie has a question for you as well. She's live in our in-studio audience.
Oh, hi.
Oh, excuse me. Hi, hello. I'm from the Manchester, Lancashire area, a bit like Mike. So I am a long way from Exeter, but it does sound like something that sounds really worth having a, having a go. And I really hope you get people involved, because I mean, I would love it if you said to me, come down. It's something that sounds really useful. For me, it does anyway. I mean, I was diagnosed with P.A.D. 7 years ago. And I do fine. I do absolutely fine. But I know the pain and how much it inhibits when you can only walk very short distances and you get that pain in your calf and you have to stop because it floors you, even though everything says, keep walking, walk through it, and you go, I can't. To the point now, I mean, I'm only in my early 60s, but now I have to use, when I'm going out and I don't know where the area I'm going, I have to use a walker, because I don't know when I'm potentially going to lose my balance or lose the ability to stay standing for where I'm going to be. So something like your research sounds like that would be a really interesting way to, to get the information to see if it works.
Yeah. I mean, firstly, Barry, thank you for sharing that. I'm obviously sorry to hear that, but you're spot on. If we could, can you imagine if we could make that exercise, that physical activity, more bearable? I mean, that's the holy grail here, isn't it? Yeah. And there's two reasons to think that's likely.
Exactly, because I mean, I'm sorry. I tried to go for a walk, but then you get the embarrassment, which you shouldn't have, of having to stop every 50 meters or whatever and hold on to something, or just take a sit down for 30 seconds. Or if you're with people, or if you're without, it's a horrible, horrible thing. And it was that way of being able to increase the blood flow and the oxygen, so you didn't get as much of that pain, and you could go for that. Would be amazing. Absolutely. If you want me to come down to Exeter, I can travel. I really don't mind.
Listen, Valerie, and obviously extend this to Mike as well if you're going to be in Canada. Listen, you're always welcome to come down to Exeter, but there are other ways of contributing, and that could be, perhaps we could have a conversation in the future with regards to, working with you so we have a patient voice on those kind of grants, because we can't do this without big funding. We just can't, and we're never going to get that funding, unless we're working with the patient group. And I think the best research is when you work with and not on people who have a disease, right? So you're welcome to be part of that process. That we'd find that very valuable.
Yes,
Valerie's amazing. So is Mike. So if you put your email in there and they can email you and participate, that would be great.
That would be great. Yeah, I mean, my claudication pain has improved so much. I mean, Kim knows over the last 12 months that last January I was really, really struggling to walk with my claudication pain. And now I do the treadmill every single day. I don't really get any pain anymore unless I'm really pushing myself to the limit. So it is just proof that it does work, and walking is the best medicine for PAD. And yeah.
So if we could make walking achievable for more people,
maybe you could work with Dr. Nasir Ahmed up there in Manchester. He's a top researcher up in that area, vascular surgeon, and he's one of the most advanced in the UK. And he would be great. If you worked with him at all, got your study at his site, partnered with him, then Valerie could go in right there. And then when Mike goes back to the UK, he could go right there as well.
Valerie, come to Devon. It's lovely down here.
I'd love to. Yeah, listen, I don't need twice telling. I'll come down. I don't mind.
Why not? You know, go for
a
couple days down in is it Southwest?
Southwest, it's beautiful. They have palm trees down there. It's beautiful. It's like 10 degrees warmer than where I am in the north.
And there's a few dollars
and it's
in
only
it.
a little drive.
There's a few euros in it for you to, you know.
No, the money's nothing to do with anything of this, is it? It's like, if there's ways of moving forward and trying to get a little bit of your health back and trying to keep that, you know, that mobility going, that's the most important thing with that.
Yeah, absolutely.
Yeah, fabulous.
Listen, I really appreciate your enthusiasm. So, you know, thank you for that.
Yeah, if you can make it down there, that would be amazing, Valerie. Let me know. Let him know. He'll put his email, right? You can put it back in there, or the person to contact to put it in there. At the very least, I'm sure that they would love to be a part of any committee and support for research going forward to help you get those grants. But as I said, you have, I mean, you couldn't have anyone better than Dr. Saratzis that's, you know, pushing, you know, right there leading, you know, research funding, you know, for the UK right now. He is one of the most advanced in, you know, overall vascular research, and he's really doubling down on P.A.D. So this is such a good fit. But whatever we can do to help, I was thinking that if you wouldn't mind giving us a quick summary. So for those who might be joining in late, I can see a few others have popped in just because I posted the link in the group. Just a quick summary on ischemic preconditioning, what it is, the theory behind it, and again, a call to action. Pull up the screen at the end where people can contact for more information on participation.
Sure, yeah, I can do. So I'll just reshare my screen so it comes through.
Perfect, we see it.
Okay, thank you. So on the screen here, this is the contact details for the very small pilot kind of feasibility study that we're doing at Exeter. Those 2 visits. So that's Kais, his PhD, Kais LLM, and you can see that email address on the screen there. But essentially, and that's what that study looks like. Okay, so 2 visits where we do ischemic preconditioning. Kim, would you like me just to recap from the top, just IPC, like just a very quick 30 seconds? Yeah,
that'd be great.
Okay, sure. Okay, so in terms of recapping, and I think this slide probably does it best. We know that people with peripheral artery disease, you know, it's an underfunded disease, and it's really debilitating. And it's a growing problem. We know that people with peripheral disease have, you know, they want new approaches explored. There is a technique called ischemic preconditioning, which involves repeated brief periods of limb blood flow restriction, typically a blood pressure cuff around the arm, and you might have that on for 5 minutes, during which time you get pins and needles, and then when it deflates, you get that reperfusion. You might do that 4 times on the arm. That technique has shown across a variety of different populations to improve blood vessel function. It's also separately been shown to improve exercise ability in athletes, in non-athletes, and there is some emerging evidence to say that it can improve walking capacity in people with peripheral artery disease. Overall, this technique is considered to be safe and generally well tolerated. So we feel there is enough reason to think that this is worthwhile exploring as that new approach that we've been asked to look into.
And is that putting it on the blood pressure cuff, then on your leg, correct?
So the blood pressure cuff always on the arm.
Always on the arm, so it can still improve the legs even though it's on the arm.
We're halfway through doing that study at the moment, right? So we know if I put it on my left arm, I can improve my right arm. We know if we put it on the legs, I can improve it on the arms. but no one's looked at doing it on the arms. Does it improve it on the legs, which is really what we care about most and foremost for peripheral artery disease. So we're actually halfway through that study at the moment, and I'd love to. This would be great for forum to talk about the findings from that. That's going to take another year to finish that trial because we need 24 people, and we've got like 11 people through at the moment, and that's really intense what we're doing. So it's always on the arm, because we wouldn't advocate using leg cuffs on people who have a peripheral artery disease. On the arm is going to be safer.
Gotcha.
I definitely want to come down to Exeter.
Sure. Listen, you're very welcome. It's lovely down here.
Yep. Even though I don't live down there, and it's probably an 8-hour train journey, but that's fine. I'll send an email, and I'll make sure everybody knows who I am.
Perfect. Thank you very much. That's much appreciated.
There's one. There's one.
Yeah, I've just got a feeling about this. I think this would be good for me. I'm being selfish, but I think this might be good for me.
Sure.
Love it.
Mike, I don't think our funding is going to cover a return from Canada. Sorry.
Yeah, no, it's fine. I'm just going through immigration, so I'm actually going to be moving to Canada. I should have my PR number over the next 3 or 4 weeks anyway, so I'll be in Canada. Yeah, but unfortunately.
But there's always ways of staying in touch, and and following our progress. So yeah, so hopefully you'll hear.
Yeah, I was just going to ask that if I could stay in touch at any point and catch up on the updates or anything like that.
Yeah, please do. So
if that's feasible.
So obviously, so I lead the group. My email's on the screen there. When we publish, we will always make sure there's a 3-minute video uploaded to our webpage. Research is painfully slow sometimes. Like I said, we've got another year to go before we finish our data collection. Then there's the analysis of this other study that we're doing. But we've got 5 or so studies in this space happening at the moment. So we're really pushing this.
And what we can do is we can also add you to our United Kingdom group. We do have a certain decorum, guardrails for anyone but patients engaging, promotional materials, things like that always have to be worded in a particular way, so it doesn't look as though it's spammy and things like that. But we can work with you on that. And I think that everyone would appreciate you in that group, right, Valerie and Mike? They would appreciate your updates, your learnings as they come, questions that you may have, things that, just bringing us along in the process, every step of the way. So happy to have you in there.
Thank you. That'd be highly valued. From a personal perspective, I spent most of my research career in a lab with no natural light. So talking to humans reminds me of why I do this. Do you know what I mean?
That's amazing. I'll put that in the group. But again, the call to action, put that up on the screen, and get in touch with his research partner and email them to let them know that you heard about the study from this video, and go ahead and see if you are a good fit for participation in not only this study, but you said you also have the grander study that is also involved with this, and you said you still need 24 more for that.
We've actually recruited for that, and that's separate. We're actually, as a proof of concept, we're not recruiting people with peripheral artery disease for that. So there's a few reasons for that, which is I can maybe explain another time, but it'd be really good to feed back the findings from that study, as and when they come through, because they have that study is designed explicitly to inform our peripheral artery disease work. So that study is going to be, that's going to be a real game changer, I think.
Okay, fantastic. Well, thank you so much.
If you ever do come to Canada and start the research, then I'll be 100% behind you.
Perfect. That's so nice to hear. Thank you. Ringing endorsement. Cheers, Mike.
Fantastic. Thanks so much, Bert. Make sure he's going to put up the screen right now that can share with you. Put up one more time, Bert, everyone we can end on that screen so people know how to participate in the research and can get in touch with you guys directly
Sure.
sooner rather than later. So here is the email he is putting up right now on the screen. It looks like qa211@exeter.ac.
That's right. So that'll get you straight to Kais, who's running that study, and my email is also on the screen there, b.bond@exeter.ac.uk for further information.
Yeah, I'll copy you in when I send the email so you know who it is.
Many thanks.
Thank you very
Fantastic.
much. It's been
Thanks
really
so much, everyone, for joining us. Don't forget, like the video, subscribe to our
Thanks,
channel
Doctor.
for more great content and updates on this study and other learnings that researchers are having on P.A.D.
Thank you.
Cheers.